Our next guest hails from New York City, which she likes to distinguish from the rest of America. We talk about rock stars in myeloma, and we have a lot of medical rock stars in myeloma, but our next guest, Dr. Donna Cadamero, is a nurse, and for us myeloma nurses, she is a true rock star. Donna is a nurse practitioner in multiple myeloma program at Mount Sinai Hospital in New York City, and she's worked as a clinical research coordinator in Boston and was given myeloma studies to work in. She enjoyed learning about the disease and working with patients so much she decided to become a nurse, and she moved to New York City and started work in an oncology unit where a new physician from Arkansas had just started and who was building a new myeloma program, another rock star in myeloma. After a year, Donna moved into the myeloma program full-time as a research nurse and eventually studied to become a nurse practitioner. 20 years later, and Donna continues to work with the same physician. They must get along well. Over the years, she's seen sweeping improvements made in treatments, overall survival and quality of life, as Angie alluded to, and in the innovative treatment modalities that are being used to harness the patient's immune system to kill off myeloma cells. CAR-T therapies and bispecific antibodies provide patients with deep and durable remissions. Donna has patients 15 to 20 years from initial diagnosis who are doing extremely well. It's very exciting. What Donna enjoys most about being a nurse practitioner in myeloma is the ability to improve patient outcomes and quality of life. She is part of the International Myeloma Foundation's Nurse Leadership Board, where she can contribute to the discussion around treatment and supportive care guidelines for patients. Being part of the foundation has been a highlight of Donna's career. So welcome, Donna. We are delighted to have you come and join us.
So thank you. This is such an honor to be in Australia to speak with you, and I know that I'm standing between you and lunch, so I will not. I have my watch on, so. And actually, this slide just shows you where we're situated in New York City. We're at the top of Central Park, and it's a very diverse neighborhood. You can see Central Park, and those houses along that street are millions and millions of dollars. But on the parallel street is low-income housing. So we really have a diverse patient population. So today I want to talk to you about supportive care, symptom management, and then new emerging treatment options right now that are available, clinical trials in Australia, but coming soon, and it's really changing the landscape of myeloma treatment. And then I want to just turn gears and talk about how I can encourage you to engage in your healthcare making decisions so you're part of the team, and then ending it off with healthy lifestyle. The healthier you go into treatment, the better your outcomes are. So there are symptoms from treatments, but there are symptoms from myeloma. So myeloma, the main symptoms, we see bone damage, renal insufficiency, kidney damage, and low blood counts. So bone disease. The majority of myeloma patients will experience lytic lesions, bone damage, and it really what myeloma does is it punches out these holes in the bone. It can also lead to osteoporosis or osteopenia. And then, fractures are very common with myeloma patients. So how do we manage bone health in patients? So there's a class of drugs that we use, biphosphonates, and it makes the surrounding bone stronger. So you're not going to grow new bone, but it's going to fortify the bone that is not damaged. So it will make it less likely for you to have a fracture. And this is all our patients are on this in the States. Patients who receive biphosphonates have better outcomes. But there are side effects, and there's always, a little good, a little bad. Something before starting these biphosphonates therapy, so Zometa is probably the most common one that we use, even though it's strengthened bones, but there is a significant side effect called osteonecrosis of the jaw, which seems counterintuitive. It actually breaks down the bone in your jaw. So prior to initiating these types of treatments, I make sure that all dental work that is needed is complete. So if there are any dental extractions or teeth that need to be pulled, that needs to happen before I even initiate treatment. So all dental work needs to be complete, but this isn't cleanings or cavities. This is when a tooth needs to be pulled. So we want all that work done before I initiate treatment. And then good dental hygiene while on treatment. With lytic lesions and bone disease comes pain. If pain is isolated to one area, we can zap it out with radiation, and this can provide quick relief for patients. But other management for pain is usually medication driven. So I just learned yesterday you don't have Tylenol, you have Panadol, which is good for pain, but maybe doesn't really relieve many myeloma patients' pain. NSAIDs, nonsteroidal anti-inflammatory drugs, so ibuprofen drugs, are good for treating pain, but not good for the kidneys. And so we know that myeloma can damage the kidneys, so anything that can damage kidneys or compromise kidneys, I want to avoid those. Opioids do provide good relief for pain, but can have some side effects as well as fatigue. There is constipation with opioids, but also there is a risk for addiction. And then steroids. So steroids are great. It's not something I would want to do long term, but that can also help manage the pain short term. And then for neuropathic pain, neuropathy, there are drugs that can help. Fortunately, with neuropathy, there's not a silver bullet that I can give a patient that will get rid of the neuropathy. So this is more challenging pain to treat, but there are drugs such as gabapentin or Lyrica that can help manage patients' neuropathic pain. So other effects of myeloma can affect the blood, so lowering of the red blood cells, which causes anemia, which patients will often report as fatigue. So if you are anemic, it's also important to rule out any other causes for anemia. So patients can have vitamin B deficiency or iron deficiency, and that I can easily fix with supportive care medications. So we want to rule out other causes. Low white blood counts, this puts you at high risk for infections, and infections we'll talk about a little bit later. It's for myeloma patients, you're already at high risk, and the treatments we give, the disease, it's a bad combination. So I look at your white blood count. If I see that it's low, I might put you on antibiotics prophylactically, or give you some medication and injection to boost up your white count. And then platelets. Patients with low platelets are easily for bleeding, bruising, so that's something I monitor, and we usually do transfusional support if they are extremely low. So I talked about the kidneys, so about 18% of patients present at initial diagnosis with renal insufficiency, so I want to make sure I protect those kidneys. And what happens is that myeloma protein clogs up the kidneys and it can't filter out because the kidneys are our filter system. So it really can damage the kidneys. Again, I look for other causes. So hypertension, so poor control of blood pressure can lead to worsening kidney disease. So I want to make sure your blood pressure is well controlled as well. And then all patients should really maintain an adequate fluid intake. So 2 liters of fluid a day really makes the kidneys happy, so please do that. And then other medications, like I said, the ibuprofens can harm the kidney. So if you're starting a new medication, run it by your myeloma doctor. Make sure it's safe for the kidneys to take. But then other things that myeloma treatment, so the treatment we give, can cause significant side effects. We talked about, the speaker before me, about blood clots. So yes, the treatment we give can lower your counts, but it can also put you at higher risk for blood clots. Peripheral neuropathy we spoke about. Actually, sometimes it's caused by the myeloma, so a small percentage of patients at diagnosis before they get even 1 drop of treatment actually have baseline neuropathy, and that's due to the myeloma attacking the nerves. And this is very hard to manage, peripheral neuropathy. Cardiovascular, so there are drugs that can affect the blood pressure. So if you're already on medication to maintain your blood pressure, I might need to add in a second medication to provide you better control. And then gastrointestinal, so diarrhea, constipation, can be very problematic and affect a patient's quality of life. So I want to separate the medications we give out by drug class. So Revlimid and Pomalyst, so we talked about blood clots, so you'll be on a low-dose aspirin. But if you decide to come visit me in New York, which I'm open arms to everyone, that's a 22-hour flight. A low-dose aspirin is not going to cut it, so you're going to have to be on something a little bit stronger as well. So it depends what your risk factor are. If you're a little more overweight, that increases your risk for blood clot. Being sedentary puts you at higher risk. And so I would say any flight over 3 hours or a long car drive where you're sitting for long periods of time is going to put you at risk. Talk to your team, and I can temporarily give you something to provide protection, especially for travel. Pomalyst, similar side effects, but this can make patients a little confused. So I would dose in the evening, so you're sleeping through any confusion. Proteasome inhibitors, so Velcade is a drug that we give usually with newly diagnosed peripheral neuropathy. So still a third of patients report peripheral neuropathy with Velcade. It's important to tell your team as soon as you're experiencing symptoms. I'd never want to get it to the point where you're walking staggered. Sometimes the neuropathy can be permanent, and I never want it to get that bad. You should be able to button a shirt. You should be able to put on your shoes. You should be able to walk down the hall. Please inform us. That might require a dose adjustment with the Velcade. And then also with Velcade, I see patients alternating with constipation and diarrhea. So we do have medications for both. You need to let us know, because again, diarrhea can affect a patient's quality of life. I'm in New York City. Patients take the subway to come to their appointments, and they don't want to have an urgent need for a bathroom in the middle of a subway station. It's New York City, though, people do what they want. Kyprolis is a second-generation proteasome inhibitor, less neuropathy, so better tolerated in that aspect, but this is where we can see the fluctuations in your blood pressure. So if you're already controlled on one medication, you might need that second medication. So I want to make sure that your blood pressure is well controlled before I even start, and then I'm going to monitor you throughout. And then you want to report any shortness of breath while on this drug, because that could cue me into something maybe cardiac-wise that is going on, and I want to monitor your heart. So monoclonal antibodies, I know daratumumab or Darzalex is used here in the second line in combination with Velcade and dexamethasone. This drug is now an injection. Before we used to give it as an IV infusion. With that injection, we see less administration side effects. So when we gave it as an IV, half the patients would have a reaction with chills, shortness of breath, and we'd have to stop the infusion and manage the patient. With this injection, very little adverse effects, so about 9 to 10% of patients may have a reaction. It's usually respiratory in nature, so you might feel a little short of breath. We give you medication before we even start with the injection. And then the first few doses, I'll give patients post-steroids, because sometimes those reactions can be delayed and patients might get that shortness of breath or wheezing. So we give patients steroids to prevent that. Overall, Darzalex or daratumumab is well tolerated, but it does put patients at higher risk for infection. So that's another, myeloma is one shot against you, and then the drugs we give you also can cause that higher risk for infection. And that's where patients get in a lot of trouble with infection. And we'll talk about how we're going to manage that. Expovio or selinexor is new to Australia. I believe it was approved in May of this year, and that's in combination with Velcade and Dex. This drug works well, but it does cause significant nausea. So we are going to give you medication, and it's usually at least 2 medications to control the nausea, and it's important to be compliant with those medications to really prevent that nausea. If needed, we might need to add in a third agent to control the nausea. So that's good communication with your team, letting us know how you're tolerating this drug, because I want to get on top of that nausea, because significant nausea can lead to decreased eating, which can lead to weight loss, and I never want that to happen. So good communication with us, staying hydrated, and that nausea control. So I just want to change gears and talk about some exciting treatments that are in the horizon. They're currently approved in the United States, but I think very soon here as well. So CAR T treatment, and you'll hear more about this afternoon. Right now it's available on clinical trial only, but this is a very novel approach. So we take a patient's T cells. So T cells are part of your white cells, and they kill any foreign invaders, so infections, but also cancer cells. So we take the T cells out of a patient, we genetically re-engineer them to target the myeloma cell. So it's like putting a little GPS in your T cells, so now your T cells know exactly where to go. So this is using your own immune system to fight off the myeloma cells. But with any novel treatment comes unique side effects. There is a release of cytokines, and I'll talk about what that implication means for patients. But this is a process. We have to take this T cells from a patient, and then they have to be manufactured. And from what I'm hearing, that manufacturing is taking place in the United States. So in the United States, usually it's about 4 to 6 weeks, more like 8 weeks. So it could be even longer for Australia because those cells are coming back to you. So that could be potentially 2 to 3 months that we're waiting for those cells. But I don't want a patient to be off a treatment for 3 months. So I often give a patient what I call bridging therapy to hold their disease at bay while we're waiting for those cells to be manufactured. Once those cells are ready, I'm going to give my patient more chemotherapy for 3 days to kill off their existing T cells to make room for the new T cells. And now those T cells are going to be infused. It's a one-time infusion, and I think of it as a living drug. So patients will get this infusion, and their immune system is constantly fighting the myeloma cells. So with these therapies, I'm going to talk about what cytokine release syndrome is. Neurotoxicity is a potential but rare side effect, but infections. So patients on these therapies are even at higher risk for infection. So I have to be more prophylactic and to make sure that patients are not getting infections. And actually, we're seeing more patients have more serious complications from COVID infection with these types of therapies. So again, it's only available on clinical trial, but I think within the next few years, it should be more widely available. It's highly effective. So in clinical trials, we're seeing patients with a 98% response rate. So almost all the patients are responding. And these are deep, durable responses. So I have a patient 8 years out from their CAR T therapy who had multiple lines of therapy, multiple relapses, and now has been disease-free for 8 years. So these are, like, I would think the Rolls Royce of treatments, not available yet wide, even in the US, but hopefully I think the wave of the future is coming. I did say that there is some neurotoxicity involved, so we do recommend patients not drive for 2 months because that neurotoxicity could happen after a patient is already discharged from the hospital. And that's why caregiver support is crucial, because if you're experiencing confusion, you might not realize that you're confused, but your caregiver will. So having someone with you who can care for you is essential for the success of this treatment. Next are bispecific antibodies, and these are the new kids on the block. And the mechanism of action is very similar to CAR T, but there's no manufacturing. So this is a drug similar to daratumumab or Darzalex, but now it's attaching to the myeloma cell, but also attaching to the T cell. So one arm grabs the myeloma cell, the other arm grabs the T cell, brings them close together, and you have the same effect. So it's mimicking CAR T, but this is a continuous treatment that patients are on, could be indefinitely. Again, patients respond well, so 7 out of 10 patients will respond, or 70% of patients respond. Cytokine release syndrome is also, so the same side effects we see with CAR T, we're seeing with bispecifics, but this is usually with the first few doses. After that, patients tolerate these treatments very well. Right now in the US, we have 3 drug approvals. They all came within the last 8 months, and we had the last 2 drugs approved within 3 days of each other. So it's been a wealth of treatment options for patients. And I like this because this is off the shelf. If I need to treat a patient now, I can start a patient on treatment, whereas with CAR T, it could be several weeks before I get that product to the patient, and it's more involved to process or to manufacture cells. Yes, cytokine release syndrome. The bispecifics that are currently available in the US are injections. So with any injection, we can see skin reactions. Also, again, infection. These patients are at even higher risk for infection. So patients need to be prophylaxed with antibiotics. We monitor their healthy IgG levels. If they are low, which they will be on these treatments, we are supplementing patients with IVIG, and that's on a monthly schedule, and that's going to provide them with some protection against infections. So you heard me talk about CRS, cytokine release. So with when we're manipulating T cells, we have a rapid, large release of cytokines. Cytokines are little immune substances that are released and can cause a little bit of havoc on with the different body systems. The hallmark sign of cytokine release is fever, and it's typically low grade, so 38 degrees Celsius, and that's why, for the most part, these treatments are done on an inpatient, and for bispecifics, we're doing the first few doses inpatient, and then after that, patients can go home. The risk period for CAR T, it's anywhere, depending on the product, could be 1 to 9 days, and usually patients are in the hospital for at least a week with CAR T, and then with bispecifics, it could be up to 10 days. Again, giving them, if they do have CRS, they'll be in a hospital setting, and we can intervene. So typically, CRS will start off as a fever. It can progress to low blood pressure or difficulty with shortness of breath. The institutions that are administering this treatment are well trained, and the majority of patients are getting fever. We intervene and reverse it. So a patient described what it's like for CRS. If you've ever had the flu shot, the next day you get a little achy with the low-grade fever. That's what patients are experiencing. So I would say overall tolerable, but there is a small likelihood that it could progress. So neurotoxicity, what is that? That can present as a headache, some confusion, tremors, and again, this is very rare. It can happen simultaneously with CRS, but more likely it happens after CRS, and then it could happen after a patient is discharged. So again, that's why I say caregiver support is crucial. This is reversible. We manage this with steroids, and we don't see any long-term complications. So infection. So these treatments that we give put patients at high risk. So just having the diagnosis of myeloma, you're at 10-fold increase of infection. Now I'm giving you treatment that puts you at even higher risk, in that drugs that actually target what we call BCMA puts patients at very high risk. So I have to monitor these patients, so any type of fever, that deserves a phone call to your team. We need to intervene right away. And as I was saying, COVID has been very problematic for our patients on these types of therapies. And we're seeing both viral and bacterial infections. And a third of patients have serious infection. And so what is a serious infection? Needing IV antibiotics or a hospital admission to treat their infection. And COVID is more serious in these patients. So any type of COVID symptom, call, test, and then we give patients Paxlovid right away at the first symptoms. So prevention, we talked about IVIG for patients on these drugs. Immunization, so vaccines in the US, vaccines unfortunately now has this stigmatism to it, but they're so important for patients. So seasonal flu vaccines, COVID vaccines with boosters. A new booster is coming out in a few weeks. I recommend everyone getting it. RSV was another respiratory infection that was very common in our patients. We finally have an approved vaccine in the US, and it will be more widely available in the upcoming weeks. So please be up to date with your infections, because if anything, infections is what really gets patients into trouble. And then changing gears again, more side effects that we deal with. So dexamethasone is usually the backbone of every treatment we give, and it literally has the most side effects, from sleep disturbances, insomnia, weight gain, mood changes, increased appetite. So understanding all these side effects, working with your team, we can sometimes titrate the dose so that you can better adapt to these changes. Constipation, and I neglected diarrhea, but we do have a lot of supportive medications that we can give patients for constipation, laxatives or stool softeners, and for diarrhea we have antidiarrheal medications. And for patients who are on Revlimid maintenance, usually patients get more diarrhea after their transplant, and that's when they start seeing their first really bad diarrhea symptoms. So we can hopefully help you manage that. You have to let us know and feel comfortable talking about it. Acid reflux, this really ties in with steroids. We do have medications that we could give. I don't want to do this long term because there's other problems with these medications. So usually when we do dexamethasone, I tell patients they need to take it with food to try to avoid acid reflux. We talked about insomnia with steroids, good sleep hygiene, don't take your phone to bed. I know my bedtime, I want it to be 10, but then I take my phone with me and next thing I know it's past midnight. So try to keep your electronics in a separate room. And if it's really affecting you, there are medications we can give to help you sleep. And then I really encourage you to be part of the decision making. You should never be told this is what you're doing without a conversation with your team. So you know yourself better than anyone else. And you really need to engage with your team and know who the team members are, from your nurse to your social worker to your physician to your general practitioner. And this really lays the foundation for a good relationship, empowers you to make those decisions, and really advocate for yourself. Voice your goals. What are you looking for in a treatment? These are my goals. I prefer something all oral. I want to maintain a job. I can't go back and forth for treatments. You need to let us know what your goals are, what your priorities are, and we can kind of titrate your treatment around your lifestyle. And then finally, healthy living. I get asked a lot about diet. I don't think anyone should ever deprive themselves. I have patients who avoid sugar at all costs, but everything in moderation. Donuts can make people happy. So, I'm never going to say no, but, healthy weight, the healthier you go into treatment, the better that you're going to come out of it. So usually when someone is frail, they don't do as well as someone who is fit. So healthy diet exercise, and I'm not talking about running a marathon, but I'm talking about going outside and walking every day, getting the body moving. These are all good things for a healthy lifestyle, and in the long term, patients do better. And then don't forget about other things. When patients are diagnosed with myeloma, they forget about everything else. Don't forget your colon screenings, your breast exams, prostate. Other things can happen, so don't neglect your other healthcare needs. So this, I believe, is my last slide. So you want to make sure you talk to your team, tell us your side effects. We can often manage them, but if you don't tell me, I don't know, and I don't want you to suffer we can work through this. So with that, I want to say thank you, and I'm so honored to be here, and I'm a part of a bigger team at Mount Sinai and couldn't do this without them. So thank you very much. And I don't know if I have time for questions.
Any questions? You're all raring to get to lunch.
I know, that's the problem of being before lunch. I will be around. You can always pull me aside and happy to answer questions. Thank you.